Great, so it looks like we're live. Okay, it looks like we're live. So my name is Carrie Wood. I'm a state representative from the 29th district, and I'm convening the Certificate of Need Task Force for Thursday, September 29th at 11 a.m. Thanks everyone for being here and for working in discussions and bringing that to the table here today. I just want to pass it over to the ranking member, Kara Pavlak-D'Amato, to see if Kara has any remarks. Okay, great. We'll continue on with the agenda item. The number 3 is approval of the minutes. Can we have a motion to approve the minutes?
So moved. Second.
Motion made by John Brady, seconded by Dan Keenan. Any discussion on the minutes? Seeing no discussion, all those in favor of the minutes signify by saying aye.
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 Opposed?
Aye.
And the minutes have been accepted. The next section is public comment. We do have 4 speakers, and Jeannie is going to give them some time to speak. I will head over to the first speaker, which is Francis Padilla. Francis, are you on?
The only one who's in the attendee list is Michael Crane.
Okay, let's have Michael Crane go ahead.
He needs to accept the permission I gave him to speak.
Okay, Michael, if you're listening,
Can you hear me?
Yes, we can hear.
Very good. And can you see me or?
No, we can't see you yet.
Yeah, my Zoom is on, but if it's okay, I'll just speak. I'm not sure. I don't see any controls about, it says join as a panelist.
Yes, click that.
And I think there we go. Sorry about that delay.
Great, we can see you now.
Great, thank you. Thank you for permitting me to offer a few comments. I will be brief. I am Dr. Michael Crane, a radiologist practicing in Guilford. I have also been the chairman of the radiology department at Middlesex Hospital and currently serve as the president of the Radiological Society of Connecticut. The Certificate of Need program, as it relates to imaging equipment, such as an MRI, CT, or PET scanner, has been reviewed by the state a number of times in the recent years. Most recently, in March 2020, the Office of Healthcare Strategy completed their review and issued a report stating, and I quote, "After careful review, the working group recommends no changes," end quote, to the program. The CON program ensures that patients' needs are being met in all areas of the state. It has the effect of avoiding an oversupply in the marketplace and preventing a concentration in wealthy areas. Small practices like mine must come up with hundreds of thousands of dollars to modernize with a new MRI. Without CON, a large medical entity could open an imaging center down the street from me, undercut pricing, and effectively put us out of business. You would be looking at the wild, wild west. As you review the CON program as a whole, please consider the Radiological Society of Connecticut to be a resource for you. We can show you that this has moderated costs and saved taxpayer dollars. We can show you that when medical practices own their own imaging equipment, that the utilization jumps and costs increase. Thank you for volunteering on this task force and for your work on behalf of the citizens of Connecticut. Thank you.
Thank you, Dr. Crane. Jeannie, are there any more speakers that have come on?
Yes, Francis has joined us now.
Francis, are you able to speak?
Yes, I am able to speak. Sorry. Good morning, everyone. I'm happy to be here. Thank you very much for giving me an opportunity. I'm Frances Padilla, and I'm president of Universal Healthcare Foundation of Connecticut. Thank you to Representative Wood and all the other members of this task force. Universal Healthcare Foundation of Connecticut is in the business of sharing and sustaining grassroots power. We believe the status quo must be disrupted and forced to change to realize social, economic, and health justice. And we start and end with the question, what about the people? So I'm here to ask you that as you take on your deliberations, that you keep that question in mind in every aspect of the CON process. Connecticut residents depend on their hospitals for access to affordable quality care without racial, gender, or economic disparities and inequities. The trends and outcomes of hospital consolidation over the past decade have made healthcare more expensive, less accessible, and more inequitable than ever before. Examples abound: rural health deserts, places like Wyndham, Sharon, Day Kimball, Johnson Memorial, Black maternal health outcomes, an aging population without access to geriatric care, immigrants left to fend for themselves. This current task force is yet another iteration of state policymakers trying to get their arms around what to do. The CON process is a vintage tool that needs to be brought into the 21st century, and it is only one of a larger set of tools needed to ensure that hospitals provide affordable, equitable, quality care for everyone. It's not the first time we look at CON. In 2015, another task force was similarly tasked. The recommendations then focused on many of the same questions as today's task force: termination, reduction, relocation of services, conversions, and more. So there was no consensus at that time and little action since then. This time, here are my suggestions as I address you. Don't reinvent the wheel. Bring in experts to address the whole group. Other states and countries are grappling with these issues as well. Develop implementation recommendations, not just high-level considerations. Get to the root causes of the problems. Very importantly, pass every single one of your recommendations through an assessment of how well it would mitigate, eliminate even, adverse racial, ethnic, gender, and socioeconomic inequities. Start there, not as an afterthought. And each working group, I think, should be tasked with this charge. Bring in experts to inform and enlighten you on how best to do that. We at Universal will continue to weigh in along the way between now and January. And again, I thank you for all the work that you have decided to take on here.
Thank you, Frances.
You're welcome.
Are any other speakers joining us today?
There is nobody else in the waiting area.
Okay, great. So we will move on. Thank you to the speakers for joining us today. We will move on to the next item, which is discussion by members. And I thought the best way to do this would be to have our discussion groups present. We have A, B, C, D, and E, I believe, 5 of them. We can have the discussions groups just talk about what happened in the groups, and then we can open it up for discussion after each overview. Can we start with Group A?
Madam Chair, this is Dan Keenan. I know that Dr. Farquhar is on, and we may be the only two from our group, but I'd be happy to report out. If
That would be
okay.
great.
All right, very good. So our subgroup, working group A, was charged with looking at the institution of pricing, tree scrap that is tied to the cost growth benchmark for consolidations, and then the second charge, setting standards for measuring quality as a result of consolidation. So we did have an initial meeting. We did come up with assignments for our members to do some call it due diligence on the recommendations. We have started doing some research, and we will be continuing that work as we move forward. So substantively, that is what we have done so far. And I would want to kind of highlight, the comment that was just made regarding bringing in. I do see Pat Charmel is on. Apologize, Pat, didn't see you originally, but another member of our Group A, and bring in subject matter experts from potentially around the country. There's a lot of work going on regarding generally the CON process, and hopefully that's something we'll be able to accomplish in our subgroup. So I'll see if any other members of the group have anything to add.
Anything to add?
No, I think that captured it.
I
Great.
agree. That's a summary. We wanted to leverage things already taking place in other states.
Great. Any questions from other members for the discussion Group A? Okay, we will move on to Group B. Is there anyone from Group B that would like to report? Okay, let's move on to Group C. Is anyone from Group C available to report?
That would be me, probably. Actually, for both Group C and D, we did a similar process. We met for the first time this week, so that was exciting. And we were able to set future dates for meetings, so that was doubly exciting to be able to get our calendars together. And we had the same approach with both. So in Group C and D, we had brief discussions on each of the topics, and I can read them if you'd like. But what we were trying to get to is what more information did we need? So similar to what Dan had just said with his group, in looking at penalties for noncompliance in Group C, or looking at guaranteed local representation of communities on hospital boards. We want to know what actually exists, and also if there are models out there. And I'd say both of the meetings were good for clarification on things. So we had someone from the AG's office giving us information in addition to the Office of Health Strategy, and that helped us clarify what some of the questions are. So we didn't come to any conclusions, but I feel like we're on a process to at least get more information so that we can have more in-depth conversation about it.
Great, thank you. And that's perfectly expected that we're going to be in the discovery stage at this point and collecting data and reviewing that. So I think maybe many of the groups are in that same point. And after a few of these meetings, we'll have probably more to report.
Mm-hmm.
Any questions for Nancy? Anyone from groups C and D that want to add comments? Okay, anyone from discussion Group E available?
I think Brenda wants to say something.
Yeah, I wanted to say something. Yeah, I had to unmute.
Go ahead, Brenda.
As far as termination of services, there's kind of a vague reference to certain services are in consideration for what are our concerned areas of termination that we're losing in the state with certain hospitals, but it's not spelled out And my particular interest in being part of Wyndham United to Save Our Healthcare is the disappearance of rural maternity units. And there are certain services that precede the closing of a maternity unit that are taken away. And I think we need to look at that formula, that if winter is coming and those icy roads, and if we have anywhere from 20 to 30 to 40 miles between maternity units, there are some days that those roads are not going to be passable. And to kind of look at what we need to stop the closures of maternity units in rural areas, because life is on the line, both maternal life and the life of the baby. So rather than just gather data, I think we need to look at what is the best case scenario of keeping services locally and what ancillary services would need to be in place, including the preservation of VBACs, vaginal births after delivery. We have over 1/3 of women giving birth will have cesarean sections. So we need to look at that number and also to see what VBAC supports are needed. Thank you.
Thank you, Brenda. The past legislative session, we defined termination of services. Has there been any, like, are you saying that the termination of services is still gray and needs further clarification?
If the end goal is to make more equality and access to care and safety regarding childbirth, no matter where you live, there will be certain services that would need to be protected to support a maternity unit. And I think we need to look at that whole package. I know that there's a close correlation between closing an ICU or downsizing it to a smaller unit that is involved with closing a maternity unit, but there are other services such as anesthesiology, such as laboratory services, such as conditions that would make different available providers for childbirth available. So I think, I would hope that would be a priority this session of the Certificate of Need. Our units are closing faster than we can get our meetings together. And for the women, and they're largely poor, many without cars, immigrants, indigenous, women of color, women in a secondary language that's not English, and who have a high postpartum depression rate. So there's a whole cluster of things that are not just in this picture. And I think we can make a difference this round of meetings if we take this as an important concern to really get energy to and to look at. I think women giving birth in ambulances on the side of the road or in an emergency room and being whisked away is not what we want to have happen in Connecticut.
So one of the things we did find in both things and was that the definition of the termination actually was super helpful, right? So it gives somebody, there's actually a defined time. But when we pushed a little bit more, just, about different kinds of things that Brenda is talking about, we were informed that there are a lot of terms that we need definitions on in order to move stronger and make things, to move forward and to make things a little bit more clear. So even, is there a set of defined, a core set of services, and what that would be? What actually, I think they said, I'm looking at my notes here, we don't even have strong definitions of what's inpatient or outpatient, and in the context of how we're talking about it. So that's one of the areas that we need as a working group, we were looking towards more clarity on. So that, yes, termination was a great thing to at least have a definition on, but there are,
Thank you.
all of these, there seemed to be some question of what the definitions of a lot of terms are. So
it sounds like you're still working through that in those discussions you're having.
Yes.
Okay, thank you for those comments. Truly appreciate it. Any other reporting on any of the discussions that happened in any of the groups? Did anyone join late that has something to add?
We can report on Group E, or I can defer to Mr. Sharmell if you want to just summarize our conversation.
Sure, please.
Doctor, go ahead. I will.
Sure. So we were tasked with the question of removing the certificate of need process completely, pros, cons, national reports, and a state-by-state comparison, which is at least one PhD dissertation if we were to do it completely. But we started the conversation, and then we'll reach out to the Connecticut Hospital Association, which should have some state-by-state comparisons. But in keeping with the very eloquent comments from Ms. Padilla beginning with things, we both agreed that the CON process is part of a larger, more complex healthcare environment, and to remove it completely without replacing all of the good things about it that it's keeping in place would really have a lot of unintended downstream consequences. So we couldn't endorse that, removing it completely without replacing it with something, but we're reaching out for more information in that state-by-state comparison and some more of the data that exists already.
Yeah, thank you, Doctor. And that's already underway. We've begun to gather that information and also some history on some states that have strengthened or in some cases eliminated CON. And then there were some unintended consequences and we're put in a position to have to reinstitute it. And we thought that that would be very instructive. We want to learn from others' mistakes as well. And so we're trying to gather all of that information. And as Doctor said, you know, we're talking about adding requirements to CON that we think they could have benefit. If we didn't have the CON process, we wouldn't be able to do those things. So whether that's building in stronger quality requirements, community benefit requirements, service specific location requirements to address identified need. If there's no framework, we can't do those things. So it seemed a little inconsistent to be talking about eliminating it when on the other hand, all the other groups are saying, how can we make it more effective?
I'm really shocked that neither of you have time to do a dissertation, but that's fine. Okay, great. So as everyone knows, the creation of the CON task force was defined in statute. So there were specific roles that we needed to fill. If you would like to participate in this, we did open up the beginning of the meetings for public comment. So we do encourage anyone that would like to be involved that was not picked on the task force, that we are all ears and welcome that. It sounds like we're also looking for experts to bring into these discussions from the outside. So there's plenty of availability for people who aren't task force members to contribute to this. And I highly encourage that. You can reach out to myself or Alex Pachakowski, who is the clerk for the committee, and we can definitely get you plugged in. That being said, I just want to ask the whole group, how is this working? Is there anything that we can be doing to better facilitate these discussions? I know a lot of it's just working with scheduling, but if there is anything that we could be doing better, please let me know or give me some comments. I don't know if anyone has any comments with that. I know a lot of it is just planning ahead. In fact, the working group that I was just participating in, we scheduled out through the end of the year. I think that's really helpful for people to have.
Hi, it's Brenda again. As I was reading through the 255-page to 217 summary, the goals of the certificate of need were very broad. It was balancing equity and social justice and healthcare justice with competitive market medical practice going on. And some of that is a dialectic pull, which way or that way. We have seen some of the very rapid regionalization and consolidation of local healthcare into large centers. And it certainly is lucrative for medical practices. It's lucrative for certain communities have enhanced services and leaving behind healthcare deserts. And I think It behooves us to look at our neighbor, and it behooves us to look at the state as a whole, that there has to be some sort of compromise here, that we cannot just allow capitalism or market rates or whatever else to pull services to only centralize large areas, and to leave other communities behind and leave them at medical risk. This is something that I think we have to look at the state as a whole. And if we're looking at what other states are doing, maybe we need to be a trendsetter. Maybe we need to set Connecticut as redone its healthcare so that more are able to benefit from the experts and the sources that are here, and that no community is left behind. I think it distressed me that both the Connecticut Medical Society and the American Medical Association were against the formation of a certificate of need in Connecticut. I think that says a lot. I think it says, they expect to be able to practice without looking back, without looking at the communities that are left behind. That I think that we need to do something different here. Currently, women of color have 3 times the maternal death rate of white women. Do we want that to continue in Connecticut? Do we want more C-sections or more pregnant women being sent in helicopters to faraway places, separated from their babies? This is things that are happening in Connecticut. I think we have an opportunity here to make Connecticut a better state for healthcare. And that what we do here in this committee will affect the lives of people in Connecticut. So we're responsible to them. I've been a licensed clinical social worker in a psychiatric unit for 25 years. I've given birth to 3 children in Windham, Connecticut, through Windham Hospital. That the medical care was outstanding, and they saved the life of my 3 children. So had I had to give birth now, I don't know what the outcomes would have been. So I asked the medical providers to look carefully before you decide to condemn a process that invites discussion of all these issues. There are people here in my district that I stand for, and I know how vulnerable they are. I know that we are the poorest county in the state. I know that we've been that way for over a decade. And what we do here and what we decide here will impact them. So I consider my sitting on this board as a public trust, and that I ask the medical providers to look carefully inside your hearts for looking in a different way rather than to condemn this process. Thank you.
Thank you, Brenda. Do we have any other comments from the committee? Okay, I will announce the next dates that we have. And these are just some things that we picked based on not everyone being able to meet at the exact time. We're trying to plan things on different time slots. The proposed dates are October 18th at 3 p.m. and November 17th at 11:30 a.m. I will put that out there and ask that if those are a major problem for you, and again, we don't have to attend every meeting because we are doing a lot of discussions on this offline. Please feel free to reach out to Alex, and we will do our best to make it work for everyone in the group. And that's it for today. So I anticipate these meetings to get longer and longer as we are doing this work. So we're not always going to get off this easy. So that's it. We are going to adjourn, and I look forward to working with everyone very soon. Thanks for your time.
Thanks, everyone.